Okay, so can a cavity be reversed? It's one of the most common questions I get as a dentist. And the truth is, sometimes yes, but most people go about it the wrong way. So in this video, I'll show you exactly what I do if I had a cavity starting right now and how to stop it before it turns into a filling. Because if there's a chance to stop it before it turns into a filling, that's what we want. But first, what exactly is a cavity? Because here's the thing, the word cavity gets thrown around a lot. And people often use it interchangeably with decay or tooth decay, but it's not exactly the same thing. So tooth decay is the process that slowly eats away at your tooth's protective layers. And a cavity is basically the physical hole that forms after decay has progressed. So here's the key. If you can catch decay early, before it forms into a hole, you can sometimes stop it and even in early stages, potentially even reverse it. When most people hear the word cavity, they imagine a black hole in a tooth. But that's a bit like looking at the end result of a house fire and missing all the warning signs that came before. The smoke, the heat, the electrical problems that all started it. And dental caries, which is the clinical term for tooth decay, is what we actually call a dynamic disease process. So it's not just bacteria eating holes in your teeth, it's a complex interaction between bacterial acids, your saliva protective factors, and your tooth's mineral structures, and believe it or not, even your lifestyle choices. So there's a microscopic battle happening right now, and your teeth aren't static structures. They're living, dynamic tissues, and they're constantly exchanging minerals with your saliva. So every single day, your teeth lose minerals, which we call demineralization, and they gain them back, which we call remineralization. And it's a bit like a biological bank account. So there's deposits and withdrawals happening constantly. Now, when you eat something containing fermentable carbohydrates, and that includes things like breads, crackers, fruits, and not just obvious sugars, the bacteria in your mouth basically metabolize these carbohydrates and they produce organic acids as a waste product. And these acids, they lower the pH at the tooth surface. So when the pH drops to below what we call the critical pH, and that's around 5.5 for enamel, the minerals in the teeth start dissolving out of your tooth structure faster than they could be replaced. But, and here's the fascinating part, your saliva is constantly working to reverse this process. So what it does is it buffers the acids, it neutralizes the pH, and it provides calcium and phosphate ions to remineralize your tooth. And this leads us to the question, which process is actually winning? Now here's what I learned when I was in dental school. This remineralization demineralization process is reversible, but only under specific conditions and only if we can catch it at the right stage. And the key insight that changes everything is we can influence which process wins. So most patients come to me thinking that dental disease is inevitable and it's just bad luck or just genetics. And the truth is, we actually have far more control over this process than most people realize. However, there's a critical time frame most of us don't know about. And if you miss this window, you're looking at irreversible structural damage that will require restorative intervention for the rest of your life. For example, fillings, crowns, root canals. And if you catch it early, you can actually halt the entire process entirely. So the challenge here is the early stages are completely silent. There's no pain, no sensitivity, nothing that would make you think, I need to see my dentist. And this is why so many people end up surprised when they're told they need extensive dental work. But there are signs, subtle ones most people miss. And once you know what to look for, you can catch the problem months or even years before the damage becomes irreversible. But first, you need to know how to recognize where you are in the process. And because each stage determines what we can and what we cannot do. So as a practicing dentist, I use a classification system that helps me determine the most appropriate treatment approach I use for each patient. And understanding these stages can help you make informed decisions about your own oral health. And more importantly, it can help you recognize what you may be able to do and what action you can take yourself. So let me walk you through each stage and what it looks like clinically and what the options are at each point. The first stage is what we call initial demineralization, and that's like the golden window. So that's where everything begins, and that's where we have the most treatment options. Clinically, what we might observe is what we call white spot lesions, and these are chalky white areas on your tooth surface that look different from the surrounding enamel. And these spots might feel slightly rough on your tongue, and they're often so subtle that most patients don't notice them. And under magnification, these areas show increased porosity, but the enamel surface remains largely intact. And think of it like a sponge that's starting to develop holes but hasn't collapsed yet. And what's happening microscopically is fascinating because bacterial acids are creating an environment where calcium phosphate minerals are being dissolved from the enamel crystal structure faster than they are being replaced. And the tooth structure is becoming more porous, but it yet hasn't lost that surface integrity. And the good news here is at this stage, with the right intervention protocol, which I'll detail shortly, we can actually reverse this with remineralization and halt the progression entirely. And I've seen patients who completely reverse these white spot lesions with consistent preventative protocols. But here's what's concerning. Most people have no symptoms at this point. So there's no pain, no sensitivity, nothing that would make them think I need to see the dentist. And the lesion might have been there for months or potentially even years before it progresses to the next stage. And that's why regular dental exams are crucial. And the second stage is what we call the enamel surface breakdown. And that's a critical decision point, because if the demineralization process continues unchecked, we can actually start seeing surface breakdown, and the enamel structure then begins to collapse, creating small cavitations, tiny holes, and pits in the tooth surface. And now we're entering into a more complex treatment decision. So the question becomes, is the lesion accessible for effective plaque control, or do we have sufficient exposed enamel surface for the remineralization protocols to be effective? And in some cases, particularly with optimal patient compliance with preventative measures, progression can be halted. But I'll be honest with you, this requires a very specific approach that not all patients are willing to be able to implement consistently. And the challenge is, once we have the surface breakdown, the area becomes what we call a plaque trap, making effective cleaning more difficult, and it creates an environment that favors acid production. And at this stage, I often have detailed discussions with patients regarding their individual risk factors, their ability to maintain an optimal oral hygiene, and their preferences regarding treatment approaches. And some patients choose to attempt conservative management with intensive monitoring, and others prefer an immediate restoration to prevent further progression. And the third stage is the dentin involvement, and I would say usually that's the point of no return. So once the caries process reaches the dentin, the softer tissue below the enamel, the situation changes significantly, because the dentin has a fundamentally different composition compared to the enamel. It's more organic, it's more porous, it lacks the ability to remineralize effectively. And that means the decay process can accelerate much more rapidly once it reaches this layer. And clinically, patients often start experiencing sensitivity at this stage. That could be thermal sensitivity, particularly to cold stimuli, or sweet sensitivity that may linger after the removal of the stimulus, or even discomfort when biting or chewing, or possibly even visual discoloration that could range from yellow to brown to black. However, and this is important, some patients remain completely asymptomatic even with significant dentin involvement. I've seen patients with extensive decay who had no idea that anything was wrong, and that's why pain is never a reliable factor to the extent of decay. And at this stage, the evidence is clear. So restoration intervention is necessary. And the question then becomes, how do you restore a tooth in a way that preserves maximum healthy tooth structure while providing good long-term function? And now moving on to stage number 4, which is pulpal involvement, or which I would call emergency territory. And if the decay progresses into the pulp, which is the nerve and the blood supply of the tooth, now we're dealing with what we call an irreversible pulpitis or pulpal necrosis. And here, symptoms can be severe, throbbing pain, pain that wakes you up at night, prolonged sensitivity to temperature. It could be pain that persists even after the removal of the stimulus, for example, the cold, or a swelling or an abscess formation. And at this stage, a root canal or an extraction is necessary. But here's something interesting most people don't realize, and it's going to change how you think about dental treatment planning. Because if you move, or the progression from stage 1 to stage 4 isn't really linear or predictable, and some lesions can progress rapidly while others remain stable for years. And understanding what influences this progression is the key to making informed treatment decisions. Now, before I tell you what I'd do if I had early decay, you need to understand that effective caries management isn't a one-size-fits-all. So what works for one patient might be completely inappropriate for another, and this is where caries risk assessment comes in. And it's probably the most important concept in modern preventive dentistry that most people have never heard of. And so it comes down to understanding your individual risk profile. So over the years, I've learned that patients who had seemingly the same oral health habits had completely different outcomes. I've seen patients with excellent oral hygiene develop multiple cavities, while others with less than perfect habits still remain cavity-free for decades. And the difference here is their individual risk factors. And so the modern caries risk assessment looks at multiple factors. It looks at, for example, biological factors, so things like salivary flow rate and buffering capacity, fluoride exposure history, the presence of cariogenic bacteria, so particularly Streptococcus mutans and the Lactobacillus species, or the genetic factors that affect enamel formation, and even age-related changes in saliva and oral tissues. And it even looks at behavioral factors, so things like dietary patterns and frequency of fermentable carbohydrate intake, oral hygiene effectiveness and consistency, the use of fluoride products, tobacco or alcohol use, and even if you're using any medications that affect the salivary function. And even if we look at medical factors, so systemic diseases that affect the oral health could be diabetes or autoimmune conditions, or medications that cause xerostomia, which is a dry mouth, or medical treatments that affect the oral tissues, chemotherapy, radiotherapy, or gastroesophageal disease, or even eating disorders. And understanding your risk profile here changes the conversation about treatment options. For a high-risk patient with early enamel lesions, attempting conservative management might not be appropriate if you can't reliably implement necessary preventative protocols. And for these patients, early restoration, for example, a filling, might be the more conservative approach in the long term. And on the other hand, if we had a low-risk patient with good oral hygiene and low carcinogenic bacterial levels, conservative management here of early lesions might be very successful. And the key here is individualized approach, and that's what modern evidence-based dentistry is all about. Now, if I noticed early signs of demineralization in my mouth tomorrow morning, here's what I would do step by step. Number one is I would understand the risk, and I'd start by trying to identify what caused it. That means looking at my snacking habits, my fluoride use, my saliva flow, do I have a dry mouth, and my oral hygiene consistency. And without knowing the why, you're just guessing here with treatment. And step number two is I would fix the diet. So I'd immediately cut out on frequent snacking, especially anything that's sugary or acidic, and I'd stick to 3 meals a day, no grazing in between meals, and only water in between meals. And this gives my enamel time to recover between acid attacks. And step number three is I would boost the fluoride exposure. So if I'm using the standard toothpaste, which has about 1450 parts per million or ppm in fluoride concentration, I might change that to 2800 ppm or even 5000 ppm. And I would brush for 2 minutes twice a day, and I would spit the excess toothpaste after I'm done brushing, but I'm not going to rinse because I want to leave the fluoride on the toothpaste. And even if needed, I would book a fluoride varnish treatment. And step number four is I would try and optimize my saliva. So if my mouth feels dry, I'd try and chew sugar-free gum with xylitol, I would drink more water, and I would try and avoid medications that cause dry mouth if possible. And your saliva is like your body's natural defense against tooth decay here. And step number five is I would clean better but not harder. So I'd make sure I'm using the correct brushing technique and flossing daily, especially near the area where the lesion is. And in this case, I would use what we call the Bass technique when brushing. So these are going to be small, circular, gentle motions, and you would basically angle your toothbrush at 45 degrees towards the gum line. And we don't want to brush aggressively here. And step number six is I would monitor it. And I would monitor the lesion maybe every few weeks. And if it's stable or improving, I'd keep going. And if it's worsening, then I might get it treated before it gets irreversible. And over the years, what I noticed is the patients that were successful with the early caries reversal aren't always the ones with the perfect oral hygiene or no risk factors. They're the ones that understood how habit change really works. And the problem here is preventing a filling is an invisible process. So there's no dramatic before and after, or even when the decay is halted, you don't really feel different. And that's what makes motivation difficult. And if you compare that with like losing weight or even clearing your skin, the visible changes are what keeps you going. But here, success feels like nothing has changed. Now, as much as I believe in preventative care, there are cases where conservative management simply isn't enough. So when a filling or restoration becomes necessary, for example, if we have a cavity in the dentin, and that's when the decay has clearly reached the dentin and has caused a visible hole. So basically, it has reached the second layer of the tooth, and the tooth structure is weakened, and delaying treatment at this point often leads to bigger problems, or even if we have hard to reach areas. So some spots in the mouth are just difficult to keep clean, even with great hygiene, and cavities in these areas often get worse if left untreated, or if we have pain or infection. So if there is nerve pain or signs of nerve damage, immediate treatment here is needed. So conservative treatment does not treat the pulp. And treatment decisions aren't just clinical, they're personal. So they depend on the size and the location of the cavity, how fast it's progressing, or your oral habits and the risk levels, or your ability to follow with care, and even your long-term goals. And sometimes that means recommending a filling sooner than you'd like, and sometimes holding off even when you're expecting treatment. And what matters most is that the decision is informed, thoughtful, and focused on your long-term oral health.